Next, we have Dr. Mary Klingensmith from Washington University, St. Louis, where she is the Mary Culver Distinguished Professor of Surgery and the Vice Chair for Education. She has numerous leadership roles within the surgical education paradigm, including the American Board of Surgery and SCORE. And she's going to talk to us a little bit today about early specialization.
Thank you, JB. The topic I was given was early specialization and training in surgery, but I thought I would expand it a bit and talk a little bit about all the current tracks that are available for training in surgery, give you a little bit of history and background for each of those tracks, and then very briefly describe residency redesign efforts. For those of you who were present for Dr. Lewis's Mark's lecture yesterday, you heard the very eloquent version of the events, and I'll just briefly touch on some of those. So just a recap of where we are with current training tracks, there are three primary tracks for residents, or I guess I should say medical students interested in careers in surgery that historically have gone through a general surgery residency program. So the first of those would be the integrated tracks, both CT, vascular, and plastics, which has had a track for quite a while. These are for individuals who can match directly out of medical school into that specialty. They're not board eligible in general surgery. There is the version that we're all most familiar with, which is a so-called categorical general surgery track, 5 years of clinical training, obviously board eligible. It is still the prerequisite to most subspecialty fellowships, and I'll spend some time talking about the flexibility rule, which went into effect in 2011, and how that has really changed that track in particular, and what opportunities there are with residency redesign as a result of that track. And then I want to tell you some about the early specialization training program. Again, that was the title of my talk and what I was assigned. This is currently only in CT and vascular surgery. These individuals are board eligible in general surgery as a result of having gone through that track. But some context as to the current state of affairs and why we are even at a cusp of residency redesign is sort of summarized here. More and more trainees in the U.S. are pursuing subspecialty or fellowship training. It's quoted to be around 80% per Dr. Lewis's talk yesterday. For the class that took the qualifying exam in 2014, it was 73% were pursuing fellowship training. But suffice to say, it's the majority of graduates of general surgery training that are going on to further subspecialty training. We do know that these so-called integrating training paradigms are very popular. I'll show you some information on that in a few moments. Those of you who are involved in intern recruitment know that very qualified applicants are applying to those tracks. We do have a backdrop of some decline in interest in general surgery since the early 2000s. There was a match year in 2003 that was relatively abysmal for general surgery. General surgery was still competitive compared to many of the specialties of medicine, but overall we have seen some return in the competitiveness of general surgery, and we know for certain that the quality of applicants to general surgery residency remains quite robust. And then lastly, I would submit to you that the explosion of knowledge and the technology advances that all of us have seen, and very well represented by this organization, by SAGES, has really made for a perception of a greater need for an individual to have a niche surgical practice. There's just too much to learn. There's too much to know how to do, how to master. And I think that's what drives a lot of our trainees to desire subspecialty training, so that they have a feeling of mastery and expertise in a defined area. I want to spend a few moments talking specifically about these integrated training tracks in both vascular and CT surgery, because for many people this is still sort of new knowledge. This is data that is current as of this past fall. There may actually have been a few more programs that were approved after the November 2014 RRC meeting. But there are 45 integrated training tracks in vascular surgery. There have only been 2 graduates to date. When these programs are all fully mature, it's expected there'll be 245 residents at any one time in these training tracks. There's a little graphic there that shows the distribution of them around the U.S., and another graphic that shows you really the explosion in the number of positions. This has become a very popular training paradigm within the vascular surgery community. The top vascular programs want to have these integrated tracks. CT surgery, only 22 programs approved to date. There are about 40 currently enrolled, but there's only one graduate to date from those programs. That person took their ABTS certification exams this past fall and did well. This is a list of all the programs there. So those programs are still relatively new, but gaining in popularity. I wanted to spend a few moments talking about the early specialization program. This was a manuscript that Jim Valentine and I wrote a number of years ago now. This was sort of our early experience. Both Jim and I have moved on from the program director role, but I thought I would give you some information about this. Interestingly, the summary that Jim from UT Southwestern and I from WashU provided is kind of current in that it's still a relatively small number of programs that are participating, despite the fact that they've been around for about 10 years. So vascular surgery was first approved for this in 2005 and thoracic in 2006. The training paradigm in vascular is that you do 4 years of general surgery, 2 years of vascular fellowship for 6 years total, and then you're done. So you gain a year, or you save a year of your training time by going through this ESP track. All of your training has to be done in a single institution, and that is true as well for thoracic surgery. There's no time gained in thoracic surgery. It's still 7 years total, but you get to spend an additional 12 months of your time on CT surgery. There's only 6 participating programs in vascular surgery, 10 in thoracic, and similarly, relatively few graduates to date, 16 in vascular and 12 in thoracic. However, these programs have been successful in achieving their stated aims, which was that they allow a trainee to get to their specialty of interest much sooner, 12 months sooner. They do get to spend an additional 12 months in that specialty of interest, and in the case of vascular surgery, they actually save a year in the training experience. The board passage rates from this have been quite good, and nearly all have sought general surgery certification so far. You may be aware that for CT surgery, it's no longer a requirement that an individual sit for their certification in general surgery, but so far everyone who has gone through these tracks has chosen to take the general surgery certification exam and have done quite well. So with that as a backdrop and as a history, the board actually took up the issue of expanding that opportunity for flexible training, that ESP anything concept, and debated this actually over a number of years, and it was adopted into a new flexibility rule at the June 2011 ABS meeting. It was initially termed the Ashley Rule, named for Stan Ashley, who was chair of the American Board of Surgery the year that it finally pushed through. And it was built on the success of these ESP programs, and this is the verbiage about the flexible training rule. Basically, an individual can have up to 12 months in the final 3 years of training to basically spend time in rotations relevant to the resident's chosen specialty. This is completely voluntary. It's done on a case-by-case basis, and all programs are eligible to participate in this. So when that rule came into effect in 2011, there were a number of us at institutions around the country that were excited about it, but also thought that it would be worth trying to do a prospective evaluation of this. We had sort of anecdotal information from the ESP programs, and we came together, initially 10 residency programs, to try to do a prospective study of this. So we first met in August of 2012. There's, sorry, a bit hard to read there, but a number of individuals from various programs around the country met for a one-day meeting in Chicago. This was encouraged by the American Surgical Association's leadership. My chair was the immediate past president of the ASA that year, Tim Eberlein, and with his help and encouragement, we got everybody together. We officially gave ourselves a name. The English major among us, John Hunter, thought we should call ourselves FIST, for the Flexibility and Surgical Training Work Group, or consortium, and that term has been used to describe this flexibility option at lots of other places since then. This is, again, our main goal is that we want to really study this flexible option with residents who have had an opportunity for additional clinical experience in their intended area of eventual practice. We hope that they'll have greater comfort and sense of independence in their practice immediately following training. And then again, as a downstream effect, as we've been talking about, as the Holy Grail, really what are the outcomes of our patients, and can they be improved by using this training track? Our ultimate goal, we aren't bashful about admitting it, is that we would like to focus and shorten training. But we do have concerns as a group about where comprehensive general surgery, or as Dr. Lewis termed it yesterday, general surgery, where does that fit? We really feel we need to strengthen and define that specialty given the workforce needs of our country. So we initially had 10 residency programs that agreed to collaborate on this so-called ESP anything. We've since had one program that's listed in parentheses down there. USC dropped out. Tony Senegor was the program director at USC, and he subsequently left that institution. And so we're down to 9 participant programs. We are prospectively sharing data and trying to determine what the best practices are of the application of this flexibility rule. I do want to note, though, that any residency program can participate in this flexibility option, and many do. And Joe Beiske, who was part of a panel yesterday sponsored by the Fellowship Council, noted that there's about 40 programs nationwide that are using this at the present time. With regard to our study, we went through the RRC, we've gained IRB approval, and we've gone through the usual avenues of ABS approval for the individual participant programs and individuals. And a lot of what our work has focused on is really trying to codify the recommended rotations for a given area of concentration. This is from the ABS website. There's a document that is housed there that is fairly high level in terms of what might be recommended. I'm sorry if it doesn't project very well, but in the case of GI surgery, it basically says experience with open abdominal surgery, not very specific. So our group came together, collaborated with the leaders of the component boards and component advisory councils of the American Board of Surgery to have a very specific document as to what would be recommended for individuals in these training tracks. And this is sort of how it looks at the present time. We have common training in all the programs, which would be either 1, 2, or even 3 years for the purposes of our study. Most of the rotations in the flexible track have really been confined to the 4th and 5th year, so there's a common 3 years, and then individuals sort of branch off. And the senior years would be tailored according to the specialty, and again, in broad strokes, we've conceived of 4 different tracks that an individual might enter, and this idea of tracking has given some clarity to the madness of trying to basically create a rotation schedule at an individual residency to make this work for the individuals who are present there. And this is an example of what the complex GI surgery recommended rotation might look like. So the 4th year would vary perhaps from an individual residency's 4th year, and that there might be a rotation in, say, nutrition and endoscopy that would not otherwise be common in that residency program. More time on things like HPB and foregut, and then a fellowship-like year in the 6th year. This is actually modeled on the ESP program for CT surgery, and we use that as our template. This is a list of our current study participants. Within the flexible track programs, we have 35 from last academic year. That's actually a typo, so that should be 2013-14, and 38 in the current year. And then we also have chief residents from last year that have served as controls for 138 residents last year. These are the data points we're collecting. We're looking at rotation schedules across all of the 9 participant sites, and then a number of outcome measures, milestones, ABSITEs, operative case logs, the OPRS, and a downstream measure of the qualifying and certifying exam results. We also have some subjective survey data, which we're collecting on an annual basis, and I have some data that I can share with you from the survey that we completed in April of 2014. I'm actually presenting this at Surgical Education Week next week. We did a survey of all the residents in our participating programs, as well as program directors, and the take-home points are summarized there. This is from all respondents, so not just those in flexible tracks, but the prevailing opinion was that flexible options will enhance resident careers, allow for more autonomy and mentorship, allow for gains in clinical and operative experiences, prepare trainees better for fellowship. But interestingly, the trainees themselves noted that it's uncertain how general surgery fits into this training paradigm. Similarly, on the program director side, there was agreement that this will enhance trainee careers, improve mentorship and mastery, but it is noted by program directors they can be very difficult to schedule, and some concern about marginalization of the non-flexible track residents. So it can be difficult in implementing these flexible tracks to provide equivalent experiences. We've certainly seen that in our study, that it's very difficult, say, for WashU to provide the same experience as is provided at Emory. And that's one of the reasons that we're actually trying to study this, is to look at feasibility and try to compare experiences. It can be really challenging to build the rotation schedule, as I was saying, and also to make certain that those residents who are not in flexible tracks have an equally rigorous and engaging rotation schedule. I do personally, as well as Dominion in our group, have concerns about the workforce that will be coming downstream for general surgery in particular. Will we make those workforce shortfalls even worse if we make it even easier for residents to pursue subspecialty training? We clearly have data that says there's a public that is in need of general surgeons. And we have some time delay until the results that we are working on will be available. I have just a few slides left and wanted to touch really briefly on residency redesign and the ABS. Dr. Lewis mentioned that this has been a topic of numerous years worth of discussion at the American Board of Surgery, but this is the most recent retreat from January of this year. This is a summary of the goals that came out of that day-long retreat. And the feeling is that some of what needs to be achieved with a residency redesign process is that we have somehow a greater autonomy in the final phases of training, some better definition of what that core 4 might be, better definition of the examination process. Should we move that? Should we change the method of the examination process? Can we work with subspecialty fellowships to determine, are there actually some common pathways feasible, and can we streamline that pathway, for instance, through this flexible training option? And importantly, how can we preserve the training of the general surgeon? The General Surgery Residency Committee of the ABS has been tasked with trying to bring to the June ABS meeting some actionable items. And this is a committee which I sit on for the ABS. We basically came up with these 4 points at the conclusion of our January meeting. The main thing that I should call attention to there is that there's the likelihood that if an individual feels eligible and ready, they could take the qualifying exam at the conclusion of the 4th year. The program would have to be in good standing and all of the requirements of the ABS met within that time frame, but they wouldn't actually be board eligible until they've had 1 additional year of supervised training. So a resolution that's out there, not sure how that will move forward. It's definitely true that trainees desire subspecialty training. We don't know what the future of general surgery is in this algorithm. We do know that these ESP tracks have been successful, and so far the flexible training tracks also seem to be at least successful in terms of meeting their subjective goals. I would submit to you that residency redesign is highly likely, but I think the timing is most uncertain at this point. I will stop there, and I'll look forward to your comments and questions later.